Hola a todos, ¿estamos ya?
Hello, everybody. Are we on air? Hello to everybody. Welcome to another session of this course, which comprises 4 webinars. This is number 2. As you know, in this course, we speak basically about the transformation of the dental office into a space of promotion of general health. In other words, we get out of the mouth and we take care of the rest of the body. And again, we have to thank you, all of you, for assisting in this course, for attending this course and this webinar. Thank you for being there. This is the most important thing. We hope this is really useful for you. Always, I would like to thank the speakers. They're excellent speakers. As you are going to see, they have a really, really high level. And they're going to speak about extremely interesting issues. Third, I would also like to thank SEPA for participating always in these education training courses and also explaining the importance of health to all the different entities. And also thank you to DENTAID, because of the effort they invest into prevention and oral health, and also for a long time now, prevention of general health, and they're compromised with the educational programs, as you can see in this webinar. I also would like to thank the technical team who are always behind. You never can see them. And as we say, always thanks to them, we are here. We're going to start the session, which is going to be really interesting, as you're going to see. It will focus on the relationship between periodontitis and chronic non-communicable diseases, which is an extremely important issue, as the speakers will explain. For that, we will start with the big 4, as we said. Dr. Nuria Vallcorba is going to speak about cardiovascular diseases, respiratory diseases, diabetes, also cancer, and the relationship between periodontitis and these pathologies. Nuria Vallcorba studied medicine. She's doctor in medicine, master in periodontics by the Complutense University of Madrid. We studied together in the first promotion of that Master of Periodontics. She is past president of SEPA. She is also now in the foundation of SEPA, one of the patrons, and she's teacher in several universities. She has received many awards, published many articles, and on top of that, she has a very big advantage, very nice thing, which is that she's a really great person. So I'll leave you with Dr. Nuria Vallcorba, who's going to speak about a very, very interesting issue. Whenever you want, Nuria, the floor is yours. Hello to everybody. Before I start, thank you very much to SEPA and DENTAID for this invitation. But to both of them, I'm very happy to be here. Thank you very much also for the introduction to Dr. Miguel Carasol. I'm going to share my screen to start with our session. One moment. As you know, we're going to speak today about periodontitis in relationship with systemic diseases, Dr. Miguel Carasol explained. Let's see if I can start the slides. Yes. We're going to speak about periodontitis and its relationship with the 4 most important diseases from in general health: cardiovascular diseases, respiratory diseases, cancer, and diabetes. And this is close to what we have to do in the dental office, because just as Dr. Carasol said, in the dental office, we have to promote health, not only dental health, also general health. Because we have to understand that patients are a whole. They're not only a mouth, they're also connected to a body. And therefore, we have to understand that we also have to focus on that level. For already some years, we have a quite extraordinary activity regarding the relationship between periodontal diseases and general diseases. And we have reviews where they found up to 57 systemic conditions which are related to periodontitis. And we've checked now in PubMed, now May 2021, When we see the number of publications we have, we see that the number is increasing a lot. It's a huge number. And we have to read all these studies to know how to act afterwards in the dental office. Some people think we are overdoing it. And sometimes we get WhatsApps in our chats of dentists. For example, I got this one, like the one you're seeing here. Without any irony, I admire periodontists a lot. But if I see the cardiovascular disease, diabetes, and now COVID, I think it is a miracle to have a periodontal problem and to be alive. Or not to mention the relationship between periodontitis and erectile dysfunction. We have to be careful because we're speaking so much about the relationship between periodontal diseases and systemic diseases that we also run the risk of losing credibility if we exaggerate about these relationships. We should focus only on those associations which are based on a solid scientific research and not only on observational types of study. Today, we're going to speak about non-communicable chronic diseases and its relationship with periodontal disease. First, we will define these non-communicable chronic diseases. We're speaking about long-term conditions with usually slow evolutions and with a combination of factors: genetic, physiologic, environmental, and behavioral factors. In other words, they're associated to non-adequate lifestyle, for example, smoking habits, lack of physical exercise, and so on. We're going to speak about 4 diseases: cardiovascular diseases, myocardial infarction and strokes, cancer, chronic respiratory diseases, and diabetes mellitus. These 4 diseases are very important because they pose a significant threat for our life. We will see their relationship with periodontitis. We speak about these diseases because these diseases are really life-threatening. 71% of deaths in the world are related to the 4 diseases we just mentioned. 30% of them are due to cardiovascular diseases. And it's especially important to speak about premature death. At present, this is defined as before the age of 70. Afterwards, before it was 60-something, now it's 70 years. 80% of the deaths of the premature deaths are related to the big 4. We have to know that these diseases, these risk factors, can be prevented. We know that 80% of the risk factors of ischemic diseases, vascular accidents, and diabetes can be prevented. This means that we should really act before they appear. On the other side, periodontitis is really, really prevalent. It is the 6th most prevalent disease in the world. If we speak about advanced disease, which in our opinion is more related to systemic diseases, we're speaking about around 11% of the population. Around 1 out of 10 persons has an advanced periodontitis. In other words, it's not a rare disease. This prevalence is quite stable. But we also see a trend towards its increase because of the aging of our population and because our patients maintain more teeth in the mouth for a longer time. Periodontitis is related to the presence of teeth in the mouth. As you know, it's a chronic and multifactorial disease, and it's associated with the presence of a biofilm, a dysbiotic biofilm, which induces a chronic inflammatory response, which leads to the loss of the periodontal attachment and the bone loss too. As a consequence of periodontitis, we have basically 2 sequelae: alterations of the quality of life in terms of health, function, because we have problems chewing or speaking if teeth are missing, because of the toothless gaps we have, also aesthetics, and also social relationships, and there we include our working environment too. And they're also related with a higher risk of suffering certain diseases like cardiovascular diseases, respiratory diseases, cancer, or diabetes mellitus, which we're going to explain now. In other words, we don't have only a relationship with oral pathologies, with oral consequences, which are important enough, but we also have a systemic effect. And this systemic effect is based on the following. The bacteria which are inside the periodontal pocket are able to enter the bloodstream, and they do so through the ulcerations of the walls of the pocket, of the periodontal pockets. We can see it if we insert a probe in a periodontal pocket. In many cases, it bleeds. This bleeding is due to the fact that we have ulcerations in the inner part. Through these ulcers, we have a direct contact with the bacteria inside the pocket, and they enter the bloodstream. These bacteria are able to reach other areas of the body. So we speak about a systemic spread of the bacteria. They are able to establish biological habitats in other areas outside the mouth. And also there's another important feature. They're able to induce an inflammatory reaction at a systemic level. This is especially important because we know that this inflammatory systemic reaction is related to other systemic diseases. We know that a low-grade inflammation is related to other systemic diseases. So we have to take into account that periodontal diseases are able to increase the levels of inflammatory markers like C-reactive proteins, interleukin-6, or fibrinogen. We also know that some persons exhibit a genetic pattern which is a hyperinflammatory pattern, and they induce more inflammation. And this has an effect on at both the oral and the systemic level. We have to inform our patients that this entering of bacteria does not happen only if we work in the mouth, if we do a scaling, if we work in the subgingival area, where of course we bring bacteria into the blood, but also in other situations which are very common in the daily life, like toothbrushing or eating, chewing. We have to explain to the patient the importance of this transmission to the bloodstream in their daily activities, because the patients have to participate in the prevention of these pathologies, and they have to know that it is essential to maintain a minimum inflammation level along the years, not to have systemic diseases. For that, not only we as a dentist have to work in our offices, but also the patients have to help us to have a proper plaque level to prevent the transmission of the bacteria to the bloodstream, and also to undergo the necessary treatments. In order to have periodontitis, we know that we need a dysbiotic biofilm. But we also know that the responsibility of this biofilm in periodontitis is only 20%. The other factors are risk factors which are environmental and genetic, and are also related to this non-communicable disease we mentioned before. The risk factors of periodontitis, like smoking, stress, obesity, diabetes, metabolic syndrome, are common to other chronic inflammatory diseases. So they share the same risk factors. So just if we think that since we treat patients affected by periodontitis mechanically, removing biofilm, but we also have to control the risk factors of these periodontal diseases. While doing so, we are also helping to control the risk factors of systemic diseases, since the same risk factors are present in the same patients in both diseases. So we have to we should ask ourselves, is it just a coincidence so that both diseases share the same risk factors in the same patients, or is there really a cause-effect relationship? And do we have more chances in these situations of suffering these diseases? In order to answer this, we have to see if certain criteria are fulfilled. They are called the Bradford-Hill criteria. We have certain criteria which we have to assess and which have to be fulfilled. One of them is that both diseases are associated from an epidemiological point of view. In other words, they're present in the same population group. But also, these diseases would have to be present before the other disease. In other words, periodontitis would have to be present before the other diseases we are mentioning. Third, there should be a biological plausibility. In other words, the mechanisms we know at present for the pathogenesis the same criteria should be applied to both types of disease. And it's also especially important what we call the impact of the intervention. In other words, if we treat the pathology, in this case periodontitis, we have to see if we have an improvement in the other pathologies where we're establishing the relationship with. And the degree of risk, we will speak about this now, about the risk of suffering a certain pathology, is the proportion of new cases of a certain disease which can be associated to the fact of having a habit or disease. In other words, the degree of risk of suffering lung cancer could be related to the smoking habit. So we should relate the new case of cancer with the fact of being a smoker in this case. We start with the cardiovascular diseases. Basically, atheromatosis type of cardiovascular disease. I want to start with a landmark, with a cornerstone article which we have in this. It's this article of 2019. It's a consensus article of the International Heart Association and Periodontic Associations, also with the help of DENTAID, like in so many of these articles, where we focus on both the oral and general health. And in these studies, it is already determined and established that there is a clear epidemiological relationship, the first parameter we mentioned, between periodontitis and future cardiovascular diseases, future cardiovascular atherosclerotic diseases. And this is true for subclinical vascular diseases, coronary events like heart attacks, strokes, and also other pathologies which maybe are not life-threatening, like peripheral vascular diseases, also create many problems. Patients who are not able to walk for a long time, they have to stop because they don't have a proper blood supply, they suffer pain. So even if this is not a life-threatening condition, it has a very important impact on the quality of life. It also is related to the cardiac insufficiency and fibrillation as the last step of this atherosclerotic disease. If we speak about risk, as we said before, we know that patients have 2.1 more chances of suffering a heart attack, especially in persons under the age of 65, 4.3 times higher risk of suffering a stroke, and 2.3 times higher risk of suffering a peripheral vascular disease. In other words, we're speaking about a quite high risk. When we speak about the prevalence of atherosclerotic disease, we know that this is related with the severity of the periodontal disease. Of course, for this we have to get rid of the other common risk factors. We know that the higher the probing depth, the higher the prevalence of atherosclerotic diseases. And the association, as we said, is bigger in patients under the age of 65. We have some problems with the connection right now, so let's see if we get the internet connection back. The association is bigger under the age of 65, as we said. How is this justified? As we said before, because of the biological plausibility. If we study an atherosclerotic plaque, we have some problems with the microphone. I'm sorry, from the translation booth. Let's see if we can get out of this. If we study the plaque of an atheroma of patients from a bypass and the relationship with the oral flora of the patient, we see that there's a bigger relationship with the presence of Porphyromonas gingivalis and Agrigatiobacter and Actinomycetum comitans, which are the same ones who are also present, and which are, so it has been seen that this flora has been associated with also presence in these atheroma plaques. Also, these bacteria are vital ones. They're not death bacteria, they are alive, and we are able to culture them. They're viable bacteria. Also, other bacteria like those you are seeing here have also been seen, but periodontal bacteria have been detected. We know that atherosclerotic diseases have been related in many cases with other inflammatory diseases, which increase the general inflammation levels. And this also supports the fact that there could be a relationship with periodontal diseases. As a matter of fact, we know that patients with periodontitis have an increment in systemic mediators of inflammation because of the presence of these bacteria which enter the bloodstream. And after reaching the liver, increment this inflammatory systemic reaction. We also have an increment of the levels of thrombotic markers and hemostatic markers, cross-reaction with antibodies, which also promote inflammation, also promotion of dyslipemia associated with this inflammation. We have more pro-inflammatory lipids present, and also we have common genetic factors of susceptibility. All these factors combined lead to an increment of inflammatory response in both pathologies. And the most important thing, as we said before, are the intervention type of studies to establish these relationships. In these diseases we're describing, it is difficult to carry out these interventional studies to see this relationship because they are diseases which are acting really long term. But we can see an effect on the inflammation. We know that if we carry out periodontal treatment, even if a peak of inflammation after the subgingival debridement, which is transient, afterwards we have a reduction of the levels of C-reacting proteins and other markers. Also, we have a reduction of the serum levels of other factors like interleukin-6 and as we said before, relation with other interleukins also. Also, we have a reduction of the levels of fibrinogen, which were augmented in periodontitis, and also a reduction of the markers of activations of platelets. And it reversed the values of dyslipemia. So we see this effect of an improvement on the after periodontal treatment on these factors which are associated to these atherosclerotic. I have to be really quick. It's a lot of information in a short time, but that's what we have to do. I will try to give this information in the most schematic way as possible. Now we're going to speak about diabetes mellitus. Diabetes is very important, as we all know, because it has a very high prevalence. It's a very prevalent condition. We know that a big part of the population is not aware of the fact that they are diabetic. It's a silent type of disease. In Spain, around 13.8% of Spanish population suffers diabetes mellitus type 2, and 6% of the population with diabetes has not been diagnosed. This means that we can do a screening in the dental office and to detect this disease in our patients who usually, when they attend the dental office, are healthy individuals. We see these two publications. One is the consensus article of the International Diabetes Federation and the European Federation of Periodontology, and also a systematic review of 2020 about the relationship between periodontitis and type 2 diabetes. If we speak about periodontitis and diabetes, we know that there is a bi-directional relationship. In other words, diabetes is related to periodontitis, and the fact of suffering periodontitis also increases the chances of suffering diabetes. If you speak about diabetes 2, we have 1.58 more chances of suffering periodontitis, a higher risk. And the periodontitis is more severe, the more diabetic we are. We know that if we suffer diabetes type 2, the risk means that the risk of suffering periodontitis increases 34%. Not only that, it increases the severity of periodontitis. And we also know that we have a worse reaction to our treatment. We speak about uncontrolled diabetes because with a properly treated diabetes and a properly controlled diabetes, we know that the response to our treatment is exactly the same as in a non-diabetic patients. So again, here, our diagnosis is also important for our periodontal control. And as we said before, it also works in the other direction. Patients with periodontitis have a 3 times higher risk of suffering prediabetes or diabetes. We're speaking about high levels of risk, as you see. Advanced periodontitis, which is what we usually speak about, increase 53% the risk of suffering diabetes. We know that suffering periodontitis increments the levels of glycosylated hemoglobin in patients with and without diabetes. In other words, we increase the levels of HbA1c, which is the level of glycemia in the 3 to 4 months prior to the determination. So it's not just one value, it's an average value, which tells us about how well the control of the diabetes is. We also know that the patients with every have a very important effect on this HbA1c, and also the patients have a higher resistance to insulin. But also, if we speak about this relationship, the fact of suffering advanced periodontitis increase the risk of suffering complications, retinopathies, micro and macro angiopathies, which are the basic complications of diabetes, 4 times higher risk of having renal complications, 5 times higher risk of terminal renal diseases, and also high risk of suffering dyslipidemia and elevation of oxidative stress markers. We know that we have 3.5 to 4.5 high risk of global mortality in diabetes with periodontitis. So, in other words, we are seeing that it's a real high risk, and also it's a real life-threatening risk. This relationship between periodontitis and diabetes, we know it's an inflammatory relationship. It's related to these inflammatory reactions we have been describing up to now, have been described up to now. We know that before suffering diabetes, we have an inflammatory reaction, which leads to the resistance to insulin, and we know that periodontitis is an inflammatory disease, so that we have a biological plausibility there. We also know that the fact of being diabetic, diabetes tooth, increases the inflammatory reaction to the periodontal pathogens and accelerates the periodontal destruction. In other words, in both cases, we speak about inflammatory processes. If we speak about interventional studies, we know that in patients with advanced periodontitis, if we carry out periodontal treatment, and we speak about periodontal treatment, we are speaking about hygienic types of periodontal treatment. We're not even speaking about surgical treatments. Just with a hygienic type of treatment, we reduce the levels of pro-inflammatory markers in a clear way, which means that we improve the sensibility to insulin. In other words, if we carry out a periodontal treatment in this patient, we reduce the levels of glycosylated hemoglobin 0.36%, which means that it has the same effect as giving a second oral anti-diabetic drug to the patient. In other words, we get a better control of the pathology of the diabetic patient. This relationship between periodontitis and diabetes is so important that when we study diabetes, and in the last classification of periodontitis, for example, we know that the effect of suffering an uncontrolled diabetes increases the grade, the evolution of patients affected by periodontitis. In other words, smoking and diabetes are the 2 most important factors affecting this grading of the disease. Let's go to the 3rd group we wanted to describe today, which is cancer. Relationship between periodontitis and cancer. Here I share with you this article of Periodontology 2000, where they speak about the relationship between periodontal disease and cancer and the possible mechanisms of relationship. We have to say that there are many, many studies which show an association between periodontitis and many types of neoplasias. As you can see here, many, many relationships have been established. But also, it's true that we have to be careful, because we need more studies in order to know if this is a really epidemiological relationship or if it's just a relationship of causal risk factors. In terms of biological plausibility, we know that for a malignant problem to appear, we need a low-grade persistent inflammation, which is, for example, created by periodontitis. We also know that some anti-inflammatory drugs can reduce the risk of cancer, of some types of cancer. We also know that the periodontal treatment reduces inflammation also. So this would go hand in hand, and this could justify a possible relationship. If we speak about the oral microbiome, there's also relations between the periodontal pathogens and some types of cancer. We've seen that inside the periodontal pockets we have some bacteria, as we said, and these bacterial reservoirs which produce some products, especially related to AA and Porphyromonas gingivalis, which could induce mutations in proto-oncogenes, which could interfere with the molecular pathways which are involved in the proliferation and or cell survival. And also, oral bacteria can activate the toll-like receptors, which are also linked to the immune reaction and to neoplasias. Also, as we said before, the bacteria as such have been related to this problem, to the presence of certain types of cancer. It has been seen that the oral flora is different in healthy areas of the mouth and areas with pathology of the mouth. In cases of oral neoplasia, in patients with colon cancer, we see a higher presence of Fusobacterium nucleatum, which creates a local inflammation. Fusobacterium nucleatum, which is present in the mouth of the same patient. Also, there are other types of cancer where a bacterial relationship has been seen. We, for example, have a high risk of carcinoma of the esophagus. If we have a higher number of Tannerella forsythia, less risk if we have Streptococcus pneumonia, and also if we have a squamous cell carcinoma in esophagus, we have a high number of Porphyromonas gingivalis also. In other words, we have a modification of our flora depending on the type of neoplasia we can find. There's also another risk factor of cancer, which is our diet. We know that some diets are not helpful in the prevention of cancer. And the fact of some patients having periodontitis and lack of teeth, this can also have an impact on the diet and can also lead to a higher presence of cancer due to this inadequate diet. Let's speak about the fourth group we mentioned, which are the respiratory diseases. For quite a long time already, we know that chronic periodontitis and a poor oral hygiene leads to a higher number of pathogens in the oral secretions. And in some areas, especially in patients which are staying in the hospital, they can aspirate these bacteria and they suffer infection in the lungs. They can suffer pneumonia associated to supported breathing apparatus, nosocomial pneumonias, exacerbation of epoch, and pulmonary and lung problems. We also know that the nosocomial pneumonia, in other words, the problems we have in patients who are in hospital, if we carry out a mechanical hygiene in these patients by toothbrushing whenever possible, or if we use chlorhexidine, for example, we apply chlorhexidine with a gauze in the mouth of the patient, this reduces the level of nosocomial pneumonia because it reduces the number of bacteria which could go to the lower part of our respiratory system through aspiration. If we speak about epoch and the relationship with periodontitis, we know that these patients with epoch have more periodontitis, and patients with epoch which have to be hospitalized has also higher chances of having periodontitis, up to 3 times more. In other words, there is a relationship between patients with epoch and patients with periodontitis. In the other direction, the fact of having periodontitis is also associated to worse parameters of epoch, a poor oral hygiene, a higher probing depth, and an attachment loss is related to clinical consequences and worse parameters of epoch. The patients have more breathing problems. The higher the severity of the periodontal diseases, the worse the pulmonary function is. We also know that these patients with epoch in some cases suffer exacerbations of their pathology. They have to go to the hospital in a higher number. And as we know, if we treat the periodontitis, we have a reduction of the exacerbations of these problems in the patient. In other words, the treatment of periodontitis would help also the condition of our patients affected by this respiratory disease. If you speak about asthma, we also know that asthma is related to severe asthma in adults, and again through an inflammatory relationship. Periodontitis can induce a hyperinflammation, which induces immunoinflammatory changes in these patients with severe asthma. The more periodontitis, the more frequent severe asthma is. We have an OR of 4.82, which means a very clear relationship. And also, again, this is happening through an inflammatory relationship, as we have said about all the other diseases as well. After seeing all these relationships we've seen, where we see that we have an epidemiological relationship, biological plausibility, and also that the interventional type of study can provide us with direct or indirect information, for example, in the case of diabetes, about an improvement in the different pathologies. What can we do in our dental office? Are we really able to do something? Or are these things that we know but we cannot do anything against? I think we should we should decide that we have to work as a team, physicians, dentists, hygienists, pharmaceutists, at all levels. Because at the end, the patient is in the center of everything. We fight against all type of pathologies so that the patient is well. And if we work together as a team, we will be able to achieve this. And we can achieve this because in the dental office, we have to start with an early diagnosis of periodontitis. In many cases, we don't have to base our diagnosis only on the appearance of the gums. We should just use a probe in the sulcus of our patients, and we should record the periodontal pathology of the patient to be able to act in a very early way if they have these pathology, because this will help them to maintain the teeth and all the consequences, which are a lot. But apart from of this, we will be able to control other systemic diseases, we said, which can be life-threatening. In other words, if we control periodontitis, if we do it properly, we can have a positive impact on the life expectancy of our patients, which is not bad. We have to start informing our patients. The patient has to turn into the main actor of his or her health. They have to change their habits. It's not just a matter of giving a pill, and with that it's enough. The patient has to be our ally, and for that we have to work. All the healthcare professionals have to work together. We have to start by informing, but we also have to imply. We have to involve the patient. We have to start with an early treatment. We have to control the biofilm by mechanical means, also with antimicrobial agents or antiseptics and intraoral antiseptics like chlorhexidine. And also in this treatment that we have to do, as we said, biofilm is essential for the pathology, but it's also essential to control the risk factors. If we control the risk factors, we know that many of these risk factors are common with other types of non-communicable diseases. In other words, just by doing this, we are already doing prevention. Apart from treating periodontal disease as such, which we know that is a risk factor by itself, it's essential to carry out a proper treatment so that we don't have any inflammation. so that we can reduce another risk factor for systemic diseases. Also in the office, we should screen the presence of diabetes as a risk factor, and this is not difficult at all. We can do it in a very easy way. If we detect a risk of diabetes, we have to send the patient to the physician to carry out a systemic control. But in the dental office, we can use tools to detect the risk, like the find risk scale. And it's very easy to do a test of glycosylated hemoglobin in the dental office. The patient doesn't have to be fasting for this. It can be done in any of the visits. And just by doing this, we can diagnose the glycosylated hemoglobin of that patient. And we can maybe screen this 6% of undiagnosed diabetic patients, which can be sent to the patients in order to control the disease. Regarding cardiovascular diseases, I would recommend the recommendation of the EFP, also of CEPA, of the Spanish Society of Periodontics, because they can really help our patients and can lead to an improvement of what we do in our dental office in these patients regarding cardiovascular disease. You have to remember that the patients we see are patients which are seen before having a disease. So everything we do to control periodontitis and the other risk factors which are common is essential, it's key. We are seeing the patients before they're suffering the pathology. This is what we always want to do, primary prevention. Also, in the prevention that we can do in the dental office, is also very important to see arrhythmia a patient could have. It's important to measure the blood pressure, for example, of the patient before a surgery, for example. We can use machines like this, devices like this, which can detect auricular fibrillations like the ones you are going to see now. The device itself detects this fibrillation, the arrhythmia, and this means that we can send the patient to the cardiologist to carry out a more in-depth checkup. For this, we have to reorganize our dental office, because we also need time for this. It's not a matter of sitting the patient on the chair, doing a prophylaxis, and working against the biofilm. We have to organize our office so that we have time for our anamnesis and to assess our patients about the control of risk factors. We have to establish circles to refer patient to others and also give written information to the patient. And also we have to update our knowledge of the teams. And of course, CEPA and DENTAID is exactly trying to do this in these type of courses. So in the dental office, we have to promote healthy lifestyle habits in order to reduce the risk of oral and systemic diseases. Here we have also the hygiene, a proper control of diabetes, proper diet. We should recommend moderate physical exercise. We should try to avoid stress and smoking. And also we should work on our social relationships, which are also risk factors, even if this is a little bit more complicated with COVID right now. So we are responsible for the health of our patient from a global point of view. And our office has to be a center of health promotion. Thank you very much. I hope that you liked it and this can help you to help your patients to be better, to do primary prevention of these chronic diseases that can pose a life-threatening effect. Thank you very much, Dr. Vallcorba. You've explained very important things and you did it very well once again. This is very important. Everything you said is very important. Because this is also very good for our profession. We're not only saving teeth, we also have the option, not only option, but also reality, we have the option to save lives. This is very important, and it's much easier than what it looks like to have an important effect on these non-communicable chronic diseases like the ones you have described. And slowly, I think this message is going to be understood in all the aspects of our profession, everything that we're explaining here, and also maybe other persons as well. So I just have to say thank you. Thank you very much for your participation once more. We have to say that the human body is a wonderful structure with many things, many organs, but it also suffers diseases. You have mentioned some diseases which are very relevant, but there are also other diseases which are also relevant, and they are going to explain by Dr. Yago Feijó. And many of these diseases are quite, let's say, trendy right now. And with not a very good relationship. For this, we have Dr. Diago Ferrolera with us. Despite being very young, he's doctor in dentistry, master in experimental science, and in periodontology by the University of Santiago de Compostela. He's senior researcher at the Eastman Dental Institute. He has published a lot and in many very relevant journals about all these issues, especially about neurological issues, which is maybe his field of expertise. This is why he's member of the group of the Spanish Society, this SEPA and the Spanish Society of Neurology working group. He received the Fonseca Award of 2019, which is the most important award of the Spanish Society of Periodontitis, and he's going to speak about other chronic non-communicable diseases, which doesn't mean that they are less important. Thank you very much, Yago, for being with us. Thank you, Miguel, for this kind introduction. I am going to share my screen. I want to thank SEPA and DENTAID for this initiative also. Dr. Miguel Carasol asked me to speak about the relationship between periodontitis and other non-communicable chronic diseases, but more specifically about neurologic diseases. Because how important are these neurological conditions? These results of the last study of global burden diseases, we can see that in terms of this capacity, they're in the top 25, these conditions. And with the aging of the population, their importance is increasing. Among the most relevant neurological conditions in terms of morbidity, we have stroke type conditions, cerebrovascular accidents, and also Alzheimer's disease. As you can see, this is more than half of the cases, both in terms of disability and mortality. First, I want to speak about strokes, especially about, strokes in the cerebral vascular diseases. Stroke is described as a rapidly developed focal disturbance of cerebral function with no apparent cause other than the vascular origin. In Spain, the incidence is more or less 187 cases of 100,000 inhabitants per year. Their prevalence is 6.4% in adults over the age of 70. It's the first cause of mortality in women, third in men, and if we combine both genders, it's the second cause. The same is true in disability. We have two big groups of strokes, ischemic strokes and hemorrhagic strokes. Ischemic strokes take up to 80% of the strokes, hemorrhagic strokes 20%. But at the end, the result is the same. Either an arteria in the brain is blocked, like in the ischemic stroke, or this arteria is broken, like in the hemorrhagic stroke. But at the end, we don't have blood supply to the brain, we don't get oxygen, we don't get glucose to the brain, and the cells in the brain die. I'm going to focus more on the ischemic strokes, because you will see afterwards that the scientific evidence we have about the relationship with periodontitis, it's much more solid in the case of ischemic strokes than with hemorrhagic strokes. And in terms of biological and physiopathological mechanisms, it makes also much more sense to relate it with ischemic strokes than with hemorrhagic strokes. Among the ischemic strokes, we have 4 types. And this classification has been used for many years, since 1993. It's the fourth classification. It speaks about 4 types of ischemic strokes: atherothrombotic, cardiomyopathic, lacunar, and undetermined or cryptogenic. The atherothrombotic stroke is a stroke where we have an ipsilateral stenosis, which is intra or extracranial, 50% more, or when we detect atheromatous plaques with stenosis of 50% at least. And also in that patient, we have to have presence of at least 2 vascular risk factors, common risk factors, like age, smoking, high blood pressure, diabetes, or hypercholesterolemia. The second is the cardioembolic stroke. In this one, the cause is located in the heart. It's not atherosclerosis like in the atherothrombotic ones. The causes are auricular fibrillation, arrhythmias. We also have congenital cardiac insufficiency, also acute myocardial infarction in the first month, especially, and other cardiac causes also. Afterwards, we have the lacuna type of stroke, which are subcortical lesions of a small diameter, about 50 millimeters, which affect the arterioles of the brain, the deep penetrating brain arterioles. In other words, it's a small vessel brain disease. It affects the small vessels of the brain. Then we have infarctions in these areas, especially. This is why it's called lacuna type of stroke. And now, last, we have the undetermined ones, which, if we think that we don't find the other causes, we decide that it falls into this fourth category. But regarding the link between periodontitis and stroke, I can summarize it in this slide. Advanced periodontitis increases the risk of suffering a first ischemic stroke. Also the risk of dying because of that ischemic stroke. It also is related to the different types of subtypes of ischemic stroke, atherothrombotic, cardioembolic, and lacunar stroke, and there's no association at present. At present, there's no clear association with hemorrhagic stroke. But what happens if somebody suffers an ischemic stroke? Does periodontitis have an influence in other outcomes with this stroke? Yes, advanced periodontitis is related to a greater neurological deficit, also to a worse functional outcome. In other words, the patients are affected by a higher disability. Also, patients affected by periodontitis suffer a high risk of suffering a second stroke or another type of cardiovascular disease, or maybe also to die because of a cardiovascular problem. What's the explanation for all this? Well, basically, there are 2 pathways which have been explained by Dr. Vallcorba, but I want to insist more on this. There are two pathways, a direct and an indirect one. The direct one is the passing of the bacteria and their toxins to the bloodstream. This happens because we have inflammation, we have ulcerations in the pocket. This way, they go into the bloodstream, or through pro-inflammatory factors, cytokines and other factors which enter through these ulcers in the epithelium. All of them are going to induce an immune inflammatory reaction in the liver. And we will have an acute phase reaction. We will have higher markers of C-reactive protein, fibrinogen, and other factors, and this will lead to a dysfunction of the vascular endothelium. Also, this will pass the hematocephalic barrier. We will have a micro action there. We have a higher inflammation in the brain, and this will create a higher prothrombotic situation, higher coagulation, and this will lead to a thrombus in the brain or to plaque of atheromas. In some cases also, there are some biological markers like MMA, which are going to break this atheroma plaques, and this leads to an ischemic problem, ischemic stroke in the brain. After this ischemia in the brain, it seems that the effect of having periodontitis or another type of infection in the gums can increase the volume of the infarct and the edema too. This is why I mentioned the high incidence of neurological problems and more alteration of function and so on. And what can we say about intervention evidence? Well, we have observational studies, epidemiological studies with many participants, where we see clearly that those patients who had undergone a dental scaling treatment, surgical or not, or with a better hygiene, or which attended the dentist more often than others, without these type of oral interventions, it seems that their risk of suffering an ischemic stroke was much lower for the future. But if we want to see clinical evidence, clinical studies, we don't have any. We don't have any primary or secondary prevention studies to see the effect of the prevention of an ictus or preventing a second stroke. There's only one protocol which was published in the United States. I think they stopped the study because of lack of funding. So we don't have data so far to confirm or not that the periodontal treatment can prevent the appearance of a stroke or a second stroke. Regarding dementia, dementia is defined as a syndrome where we have a deterioration in memory, thinking, behavior, and also in the ability to perform daily activities, which goes beyond from what might be expected from the normal aging. In Spain, the numbers are quite worrying. In subjects over the age of 60, dementia affects 5 to 8% of the population, and this incidence increases exponentially with age. You see that between the age of 60 to 64, it affects 1 of every 1,000 subjects, but at the age of 90 or more, we're speaking about 70 of every 1,000 who are affected by dementia. Every 5 years, in persons over the age of 65, we have the cases are doubled. At a worldwide level, I don't know if we could call this an epidemia or pandemia, but more than 50 million of subjects are diagnosed with dementia worldwide. There are many types of dementia, but 2 have been clearly related with periodontal disease. The one is Alzheimer's disease, which is the most prevalent one, which is a neurodegenerative disease, and the second one is vascular dementia, which is the second most prevalent dementia. In Alzheimer's disease, we see an accumulation of beta amyloid, which creates this senile plaque in the neurons, especially beta amyloid B42, and especially the accumulation of a protein which is called tau. And after phosphorylation, it creates these neurofibrillary tangles. And this leads to this cognitive deterioration in patients with Alzheimer's disease. But this doesn't appear suddenly. This progresses over the years. We have a preclinical phase. We have an asymptomatic phase of 10 to 15 years, and afterwards a symptomatic phase with a mild cognitive deterioration. Afterwards, it advances until it reaches the stage of dementia. In the vascular dementia, the origin is a vascular brain disease. It could be an hemorrhage of a great or small vessel, micro hemorrhage. It can be because of multiple infarctions in the brain, small ones in the brain, microangiopathy in the brain, like lacuna type of stroke or leukocytosis, which is a problem of the white matter. And this leads to a vascular dementia. This can appear in a more sudden, more acute way, more sudden way, because it's related to these problems. Also here, if we have advanced periodontitis, we have a higher risk of a cognitive decline in dementia. Also, the 2 diseases we mentioned, the higher risk of suffering Alzheimer's disease and vascular dementia, and also higher risk of mild cognitive impairment. These are cohort studies, which are prospective studies. So first, you detect periodontitis, afterwards you develop these problems. Also, we've seen that if we have infection in our gums, it seems that the results in the cognitive tests are worse in patients than in patients without periodontitis, if we have periodontitis. Why does this happen? The first phase is the same one. The pass of bacteria into the bloodstream we have a hyperemia, also the inflammatory markers, which enter the bloodstream to create this state. This will produce microglial activation and neuroinflammation, and this will lead to a neuronal death. Also, this inflammation is going to lead to deposition of amyloid beta. It's going to phosphorylate the tau protein, and this is going to lead to these neuritic plaques and the neurofibrillary tangles. All these things lead to the cognitive decline type of Alzheimer's disease. On the other side, the vascular changes we saw with the appearance of thrombus in the brain arteria and the atheroma plaques, it's going to lead to cerebrovascular disease, which is also going to lead to cognitive decline. Regarding intervention, we have observational types of study and epidemiological study on very large databases where we try to see a tendency in the sense that patients which have been treated periodontally have a lower risk of suffering dementia than patients who have not undergone periodontal treatment. On the other side, persons diagnosed with periodontitis which did not undergo any treatment seem to have a higher risk. Also, those who don't attend to the dentist on a regular basis, they also seem to have a higher risk of suffering dementia in the future. If we speak about clinical studies, well, we go back to what we said before. We have a very limited evidence. There's only one study which was published at present, and it's not about periodontal disease, but dental treatments. They studied patients with mild Alzheimer's disease, and they treated them for all their oral pathology. After 6 months, they saw that the cognitive function seemed to show a function towards an improvement. But as I said, it's a very limited, very scarce evidence. At present in UK, 2 clinical studies have been registered where they're studying if the periodontal treatment, surgical or not, in patients with mild dementia or with mild cognitive decline can have an effect on, first, the periodontal status, which is the primary outcome, and secondly, on the cognitive results. These are studies with 1 to 2 years of follow-up, but we are still lacking information to know if the periodontal treatment can act as a preventive primary or secondary treatment for dementia. I think that our colleagues who are neurologists, they want to have our help for the prevention of strokes and dementia, and they want to have non-pharmacological treatments. And here I would like to defend our profession, because we have very solid evidence showing that the periodontal treatment is a non-pharmacological anti-inflammatory treatment. We know that our treatments reduce the systemic inflammation and improve the endothelial function. If we could design studies where, after a proper selection of the population, type of treatment, type of comparison, and the follow-up, if we could see that if the periodontal treatment can improve the cognitive situation or reduce the risk of having a first or second stroke, especially if we do it on high-risk populations like patients with diabetes or high blood pressure, which are 2 very clear risk factors for dementia and strokes. Also, in the lower part, as Dr. Nuria Vallcorba explained, of the slide, you can see that in our dental office, tomorrow, we can do things to try to prevent in the future the appearance of cerebrovascular problems or dementia. For example, if we measure the blood sugar levels or the blood pressure or cholesterol to see the cardiovascular risk scale, we all know that these are risk factors. Diabetes, cholesterol, smoking, all these things are also very related to periodontitis and dementia and strokes. I would like to finish with 3 take-home messages. The first one is that periodontitis is linked to a higher risk of suffering ischemic stroke and dementia. Regarding the biological mechanisms which could explain these associations, the base is inflammation. The systemic inflammation caused by periodontitis, which is going to induce other biological factors like a thrombus and ischemia or even neurodegeneration, hypercoagulation, thrombosis, neurodegeneration. Last, even if we have observational proofs, we don't have clinical evidence which proves that the periodontal treatment is able to prevent at the primary or secondary level the appearance of strokes and dementia, especially in Alzheimer-like disease. Thank you very much. Thank you for listening to me. And I hand over the microphone to the moderator of this session. Thank you very much, Dr. Leira. Thank you very much. This is Dr. Vallcorba. This was a spectacular lecture and about a very important issue. As you see, I mean, we are increasing the importance of dentistry on the human being, even if it doesn't sound very humble. Because we are treating patients who are chronic patients or where we have to prevent the chronic appearance of periodontal disease. And this is a very interesting option for us to be able to prevent, if possible, all these groups of systemic diseases which are so important and which worry us a lot. I mean, I'm not saying at present that cancer and cardiovascular disease are not important, but neurological conditions also have gained a lot of importance in the human diseases because of their devastating effects on the social relationship, family relationships, and so on. I think we have to continue working in that direction. Thank you very much, Yago. It was a wonderful presentation. And just to finish, because this wouldn't make sense without what Dr. Sonia Miravet is going to explain right now, but we as dentists, we can do a lot of things in prevention, but we have to count also on the physicians. We are speaking about non-communicable chronic medical conditions. And if we have to speak with somebody, with people of primary healthcare. Dr. Sonia Miravet is going to explain how to establish these relations between dentists, primary physicians, and so on. Sonia Miravet, a specialist in family medicine. I have to read this. She works in the primary healthcare of the Baix de Llobregat, Alt Penedès, and Garraf. Sounds really great where you work, these regions. She's also part of the diabetes work group of Semergen. She's vice president of Semergen in Catalonia, Spain. She's published a lot about this. She's working also on diabetic retinopathies right now. We want to thank her especially for being here, because her opinion is really valuable for us. So Sonia, whenever you want, thank you very much for being here. Thank you, Miguel. I would like to thank Miguel Carasol, CEPA, and DENTAID for giving me this opportunity to share with you some aspects, which, if I'm honest, I was really surprised. And we can speak about this in the presentation, but especially I would like to say thank you to Miguel in this case, and to DENTAID and CEPA, because they allowed me to discover a world which, if I'm really honest, I didn't really know that well up to now. And just as all my other colleagues of primary healthcare. So I think Miguel has planted this little seed, which we have mentioned in our private conversations before, but we discussed what we could do. And I thought a lot about this. Well, at least this little seed turned into a plant, and we are working right now, as you said, we are working on coordinating with you and and to do the best we can for the benefit of our patients. I'm going to share my screen. And we start our session. We will speak about the dental office and general health from a very humble point of view. As a primary healthcare physician, I am. But I want to mention some things which I think that we have to explain. These are my potential conflicts of interest. I have to confess that for this session, none of them are applied. But this allows me to improve of the oral and general health of our patients in our offices. First of all, I would like to start with this image. Maybe this is not really impacting for you because you know this, but with this idea that the dentist, that the mouth it's just one area there, which is not really related to the other systemic diseases. Dr. Vallcorba and Dr. Leira have explained very well in the excellent presentation that this relationship between poor oral health and periodontitis with other types of diseases. And at least these relationships, in some cases, we have this causal relationship, but here especially gastrointestinal problems, cardiovascular problems, cancer of the esophagus and colorectal cancer. Also adverse pregnancy outcomes, and also the relationship with diabetes, which a field which is really, really important for me, the insulin resistance. So this is also an image which I use as an icon, and I explain this to my colleagues, so that we can see that the mouth goes much further than what we thought before in relation with these pathologies. In this article by Montserrat, this was mentioned also by Dr. Vallcorba, periodontitis was related with many other diseases. She mentioned 57 of them. And there are possibly many more comorbidities in the cases of the patients that we treat in our offices. Because at the end of the day, as you are going to see, we are seeing basically the same types of patients. Cardiovascular diseases, especially also in the field of metabolic syndrome, diabetes, musculoskeletal diseases. And there we can work much more in terms of prevention. And I also I want to approach this session from the prevention point of view. How do we visualize that preventive medicine, this preventive and community dentistry or medicine? We have always centered on the family part of the medicine, but not so much on the community type. It was like it had less importance before. It was on a second plane. In dentistry, you have three types of prevention. Primary prevention, to avoid the disease to appear. There, you as dentists and we as physicians, we have to help the patients and establish proper oral hygiene, healthy diet, to avoid toxic and negative habits. But maybe we recommend so much the periodic attendance to the dentist. In terms of secondary prevention, after the disease is present, we want to prevent the effects of it. And there, the early diagnostic and treatment is very important. It's very important for us to interact there in our offices. Tertiary prevention would mean that we want to limit the lesion, which goes beyond the disease as such. And I don't know if you work a lot with a quaternary prevention, but also trying to avoid these over treatments, over prescriptions in a fragile older patients, where we should maybe use not so many medications, but we should insist more on the primary type of prevention. Why don't we advance in that prevention? I have to start with mea culpa. These are factors which affect the prevention of health. This is an important scheme which affects the different barriers which affect the implementation of this activity. We have intrapersonal factors in the person as such, regarding their beliefs, their skills, their knowledge, their experiences. Maybe we think this is a disease which cannot be prevented or it's more difficult. Also interpersonal factors, different specialists, primary healthcare, hospital specialists, institutional factors. In other words, the primary care organization sometimes is not helpful. We have to have tools also, and also a biomedical model which has not been developed really for this promotion and prevention of health. There are also community factors which affect the implementation. Mass media, our present cultural context, and last, the public healthcare policies, the health system model that we might have. And sometimes these short-term goals we have from, and the political health short-term goals don't allow us to see the long-term goals. If we insist on the activity of this type of patients in Spain, what type of activity you do in your offices, at least those of you who responded to, who answered to this questionnaire, we see that 80% of our time, more or less, we devoted to prevention. Most of our time is devoted to treatments, to curative procedures. This is the time that we devote to different activities. Well, just one comment. I've mentioned any study here, but in primary healthcare, I'm sure it's quite similar in this sense. We don't devote too much time to prevention. What are the features of your population, the people you see in your offices? This is the mean age of your patient. Probably you see younger patients than what we see in primary healthcare. And this is an opportunity, as you're going to see afterwards. Even if Miguel Carasol mentioned in the previous webinar that the projections are that we are going to see older patients with time. And maybe the prevention is going to be different in that sense. But I hope that we will work together to establish this. But bringing this to my field now of diabetes, what are the features of the diabetic patients we see in primary healthcare? This is a study which was done in the database which we have of diabetic patients treated in primary healthcare in Catalonia, Spain, with a very high number of patients you can see here. They are older patients, most of them male, and 30% of them are over the age of 75, quite old population. This is the body mass index and the different levels, but also they have a high number of comorbidities. 82% are going to have 2 or more, and most of them are going to have other factors like high blood pressure or other risk factors. So we have a combined prevalence of different metabolic risk factors, of cardiovascular disease also, and chronic renal disease. And this means that we have to apply a really comprehensive approach. The comorbidities have been mentioned before: high blood pressure, dyslipidemia, obesity, cardiovascular diseases, kidney problems. And in the last image, you see this mesh of pathologies. This comes from a very interesting article. It's a cohort of diabetic patients which are compared to other non-diabetic patients. You can see how the comorbidities are related among them. The circles show us the degree of relationship. For example, diabetes with cardiac arrhythmias, like Dr. Vallcorba mentioned. Long-term use of insulin, respiratory problems. And it's very nice because it's like predictive models. So because also the reaction of a diabetic patient with some comorbidities is going to be different from another one. It's a really interesting article. This has also been mentioned before. The patient as the focus of our attention. This refers to diabetic patient, but it can be extrapolated to all chronic patients. Our goal is to reduce complications and improve the quality of life. In the case of diabetes, we also want to reduce the cardiovascular risk and the mortality, but we are trying to improve the quality of life, just as you do in your offices. So first, we have to take into account the features of the patient. We have to see the factors which are going to impact our treatment. The decision making has to be shared for the treatment plan, because there's no worse drug than the drug that the patient is not going to take, or other measures that the patient is going not to be implemented. We have to implement the treatment plan, have to do a follow-up and continuous support and review it and agree on a combined treatment. This is an image on our clinical history in the primary healthcare, and which we have in Catalonia, which is used in 70% of our population in primary healthcare and also in the hospitals. And what you see here is this little tooth. This is the part of dentistry. If you click here, you see this little image here, you see on the right. And here on the left, I mark the different standards of the standards that are required from the colleagues, our colleagues, the dentists. So here we see the oral exam in diabetic patients, and these patients with risk of oral cancer. We see children of 7 years, or 12 years of age with different standards. We also see the treatment with conservative dental treatments in these children. Also, we have pregnant women. We have also the situation before extracting a tooth. So this is more focused on an oral exam in patients with a poor metabolic control, and also the issue of prevention. Maybe there we have it more present. In that sense, and if we speak about the pathologies which are more related to diabetes or in more vulnerable populations, we have to think also about the cardiovascular health. What can we do? We do not only have common risk factors in our patients. Periodontitis leads to this chronic inflammation like obesity or diabetes, which means that we share the same cardiovascular risk factors, but also in, for example, smoking. We know that smoking is an independent risk factor for both periodontitis and cardiovascular diseases, and 28% of Spanish population smokes. We have to explain that we should try to help the patient to quit smoking. The dental office is a very good opportunity for that. And of course, we have to do an early detection of oral cancer. In terms of prevention, as Dr. Vallcorba said, the detection of patients with high blood pressure can be extremely helpful for us. Also to promote the self-management. This happens with diabetic patients or patients with chronic diseases, this education of the patient. And also we should try to avoid the adverse effects of our drugs and their possible interactions with other treatments. Also the promotion of lifestyle, of changes in the lifestyle of the patient. I'm sure that you ask your patients about the diet, for example, and this means that you also can promote healthy lifestyle habits. I would also like to invite you to this next webinar, where Dr. Miguel Carasol is going to present this protocol for the dental office about the most important risk factors. I'm really excited to attend to that webinar. Regarding the risk factors, Dr. Vallcorba mentioned the importance, for example, to measure the blood sugar levels. This is a study which was done in Sweden with a national database with a very important cohort, and these are real-time values, not clinical studies. We have this idea that the hemoglobin levels have an effect on the microvascular problems, but also on infarctions and other problems. Here it comes in the 4th level, but smoking and physical exercise is at the 1st and 2nd area. So we have to insist on that also. In the same article, they published a very interesting analysis. For example, diabetic patients have already an excess mortality, of cardiovascular risk and other problems, more than other persons who do not suffer diabetes. And if we compare and we see 1, 2, 3 risk factors of cardiovascular disease in young patients, as you can see, look at this orange area, we have a much higher excess mortality than in patients without these risk factors, or in elder patients even. So it's very important to know that the more uncontrolled risk factors, the more mortality, the more cardiovascular disease, especially in young patients, which maybe don't come so often to our clinics, but that you can see in your dental offices. So maybe you should think about this. So in these young patients, why don't we do something? In diabetes too, this is a very helpful image. But in every chronic disease, we have a lot of therapeutic inertia, clinical inertia. So we should see how to approach this. For example, here, we should also start with a mea culpa in many cases, because in many cases we have a poor communication with the patient. Patient have their expectations, their beliefs, they're afraid of the needle. We have to work on that. We have to improve the devices, we have to improve the therapies, and especially self-management, also with programs or mobile apps. Also, other actors have to be involved, like psychologists or diabetic educators, nurse-led management. And we have to combine everything. We shouldn't do this on our own. We should work on an interdisciplinary level. Pregnant women, this is also important. You see them in your offices, and when they express the desire of getting pregnant, we should start with the importance of oral health and periodontal health during pregnancy. Other aspects to assess are the identification of the moment of the pregnancy, personal risk factors, toxic habits, and also a periodontal exam to study the different factors. In children and adolescents, this is also an important factor, because we don't see them in many cases in our clinics. But the dentist is able to promote an optimal habits in oral habits and speak about healthy lifestyle habits. And you can detect them early. You see bruxism and other problems, and act early. Also in elderly patients and fragile patients, this is a very interesting article. It's from the NHANES study of 2016, where they studied elderly patients with different diseases, and they asked them also about their oral health. These 6 factors, which have been mentioned here, have a significant relationship with oral disease. What happened during the pandemic? It's true that the primary care and also hospital care has been blocked for a certain time. And also in all our indicators of our treatment quality have been reduced, because we have been busy treating our COVID patients. Here, for example, you see this joke, somebody is operating on himself on a virtual basis, telematic basis. For example, we have a reduction here in the exams of diabetic problems and screenings. We should take this into account. What opportunities have arisen during the pandemic? We have had a great work team, multidisciplinary work team. We have seen new roles and professional profiles. We have to be able to manage our own agenda. We have to value the patient in a more adequate way. We have to be proactive, especially in telemedicine. But also we have an opportunity, because patients which we didn't see before, now with these telematic options, we were able to see them. This opens a lot of opportunities. We have to go for more personalized medicine, also in dentistry. And we have also to assess the risk in the different moments and adapt to the patient, depending on the risk, for example, periodontal disease, to, for example, the number of appointments they need. Also, we in our clinics, we can do a really quick screening to work together with you in that sense, you, the dentists, The most important part is the education, collaboration, and the empowering. To share with the patient the evidence we have, to see which are the patient's preferences and approach them from our clinical experience point of view. I'm going to finish with this regarding opportunities. This is a very interesting recent articles about the promotion of health. We have to stop carrying out activities which do not provide any value. We have to promote the self-management of the disease and health. We have to have a proactive communication between professionals and patients. And this is a summary of their opportunities. And point number 3 is speak about the multidisciplinary teamwork. Family, primary healthcare physician, nurses, social workers, and so on. And I would like to add the dentist here, as Dr. Carasol said before. And we're moving towards a new model of integration. We have to implement this integrated model. This will lead to our professional development. We have to educate all the actors. We have to provide a better access to the dentists. If we try to do it, we can achieve many of these things. And we also will promote these issues. I mean, I wasn't so aware about these things, but SEPA is really leading this process. I'm not going to speak more about this because Javier is going to speak about relationship between coordination between dentistry and primary healthcare. But I would like to say that the 5 messages I would like to convey, not to you because you know it, but to my colleagues of primary healthcare, is that we should make the professionals of oral healthcare more visible, like a key agent in the promotion prevention of health. Also, we have to explain that periodontitis is a risk factor for cardiovascular disease, which some, maybe not everybody knows. We have to adapt the needs of our care and our clinical manager to every situation. We have to customize, to personalize it to the biopsychological and social problems, because we're going to face a wave of psychological and social problems. We have to promote the change. We have to anticipate. Sometimes we have to stop, take care of ourselves, to be able to take care of others, to adapt to this new situation. And this is an opportunity. I would like to thank again for inviting me to be with you in a day like today. Thank you very much. Thank you very much, Dr. Miravet. If you stop sharing your screen, I think I did. Is it better now? One moment. Okay. Okay, now I can see it. Spectacular. I mean, maybe you were surprised about what we do in dentistry with general health, but I'm surprised what you do in primary healthcare. And this is so important. We have to be important. We have to accept how important it is to help out each other, to coordinate for the benefit of the patient. And also from a preventive point of view, you can teach us a lot in that sense. And if we can teach you something, we will do so too. In other words, communication and collaboration. I think this course is very special in the sense that, in a certain way, we are establishing links between each other. We have to start somewhere, and we still have 2 more webinars to go. Yes, and 2 very interesting ones. Yes. Thank you very much, very much. I'm really overwhelmed with your presentation, and I mean it. I think this is very beneficial for all of us in our profession. So, of course, I just have to say thank you again to you. Thank you for all the persons who participated in this webinar, which is number 2 out of 4. I would like to thank once again to SEPA. And I would also like to thank DENTAID once more, because they have understood how important this relationship is between oral, dental, and systemic conditions is. And also, maybe maybe we are scared now seeing how many chronic diseases there are, but also we have seen what we can do to prevent maybe not their appearance, but maybe we can prevent the evolution to a worse situations. This webinar has been a little bit longer, but this was done on purpose because we thought it was really important. And in the next one, as you will see also, we will continue speaking about the relationship between the oral cavity and the rest of the body, which is what we are all interested in. So take care of yourself, everybody. We see you again next week here, if you want to be here. Thank you very much.